Hi, everyone. This is Larry Tong, and I am joined by Dr. Sam Rhee and Dr. Sam Jejurikar. Uh, we are at Yorkville Plastic Surgery. For me, Sam Rhee is at Bergen Cosmetic, and Dr. Jejurikar is at Sam Jejurikar. Welcome, gentlemen. Today, we have a discussion about the current trends in breast augmentation. This is a very common procedure that we all do. But before we go on to that, Sam is going to read our disclaimer.
This show is not a substitute for professional medical advice, diagnosis, or treatment. This show is for informational purposes only. Treatment and results may vary based upon the circumstances, situation, and medical judgment after appropriate discussion. Always seek the advice of your qualified health provider with any questions you may have regarding medical care, and never disregard professional medical advice or delay seeking advice because of something in this show. Sam Rhee, you want to lead this conversation about trends in breast augmentation? You were just telling us some interesting stuff you had found.
Yeah. So in 2022, ASPS, the American Society of Plastic Surgeons, did a survey, and they analyzed the trends over time in terms of breast augmentation. And a lot of plastic surgeons, as part of the society, logged their breast augmentation cases over basically 15 years, from 2005 up until 2020. And some of the interesting trends that they found with cosmetic breast augmentation included the following. One was, I think, which is pretty obvious, patients are less likely to smoke, 12% versus 8%, which is staggering that 8% of patients are still smoking when having surgery. They were more likely to have sagging, 23% versus 20%. And we need to talk about this. I want to get to the sagging part of breast augmentation and dealing with that. The use of inframammary incisions, which are the incisions under the breast fold, increased from 68% to 80%. The use of periareolar incisions around the nipple decreased from 24% to 14%. And then the next to last statistic that I wanted to highlight was the submuscular implant, or under the pectoralis major muscle. That increased greatly from 22% to 56%. And I would really like to talk about implant placement above or below the muscle and what you guys think. And then the last one,
just so I understand that, they're saying 15 years ago, only 22% of implants are put behind the muscle?
That is correct.
Oh, wow. Okay.
Yeah. And then the last one, which I think is pretty obvious considering the ALCL and the issues with textured implants. Basically, textured implants have dropped to 0% at this point. They used to be like 16% back in 2016. So there's basically no use of textured implants anywhere at this point. So what do you guys think of these what's your initial take on these statistics and the changes over time with breast augmentation?
I'll go first. I mean, they all seem like they're science driven, which is good. Inframammary incision is more common because there's data that shows that capsular contracture, which is, for the viewers, is hardness around the breast, is less common through that axis. So I like that. Same with the trend towards subpectoral implant placement. I mean, there's data that shows that subpectoral has less capsular contracture than subglandular, which is behind the gland. So that sounds really good. I guess the thing that got my attention was how little breast augmentation was actually done through a subpectoral approach until recently, because we all trained at a place where subpectoral was the default, and that has sort of been my default as well. You said that there is more sagging that doctors are seeing now than there was 15 years ago.
Well, minor, from 20 up to 23%.
I guess that surprises me, because at least the trend in my practice has been towards smaller implants, and we use scaffolding mesh a lot more to help try to prevent that complication. So that surprises me a little bit. What do you think about that, Larry?
I think that sagging definitely occurs post surgery. One interesting thing about it is that I think that if you put the implant under the muscle, that will diminish that, because you're not having the weight of the implant just solely borne on the skin, which happens when implant is placed above the muscle. So I think with the use of mesh and using smaller implants, meaning more support and less heavy implants, there's a trend to minimize that. When Sam had just initially mentioned that statistic, I had initially thought that it was related to seeing patients with sagging preoperative. And I think that's actually an interesting topic to discuss as well. What do you do when you see a patient who has sagging? In general, we would have a discussion about mastopexy or breast lift in association with breast augmentation. But I find that once we get into that realm of discussion, there's a number of patients who are a little bit resistant with that because of a number of reasons. And I'm just wondering, first of all, when you evaluate a patient and they have sagging, what are some of the things that some of the criteria that you would use to evaluate as to whether or not they need a breast lift?
You want to take this, Sam?
I was going to say this is probably there are several different, I would say, nexus or decision points that patients have to make when they're considering breast augmentation. And the first one is, should you even get breast augmentation with an implant? And that's something that we all, as plastic surgeons, talk to patients and try to determine the reasons behind why a patient would want it. Would an implant help reach their goal in terms of aesthetics and what's going on with that? Understanding the risks and the benefits and risks with an implant, which are very important, obviously, for patients to understand. And then there are a couple other decision points: size, location, and we just talked about like incision placement and implant placement. And all of those things have to be discussed with the patient. Another big nexus point or decision point is, as Larry just said, what do you do with sagging? And, some of it depends on the patient's goals. But the biggest one, I think, that we're sort of headed toward where we're headed when talking about aesthetic breasts is incisions and scarring. And when you do a mastopexy or a regular type of breast lift or most breast lifts, you're talking about significant number of incisions on the breast. Not only, and we can talk about these and which ones do you guys prefer, but it's a hard stop for a lot of patients to say, I'm going to put an incision right in the middle of your breast, under your breast, around your breast. A lot of patients find that to be difficult to accept for correcting saggy breasts. And I think as plastic surgeons, that's one of the biggest things we have to work around when we're dealing with patients and their goals with their breasts. How do you guys deal with that when you first initially talk to patients?
I think, first of all, we even have to define what sagging means, because as weird as that sounds, I find that plastic surgeons and patients oftentimes define sagging differently. Plastic surgeons
100%.
define sagging as generalized descent of the nipple and the areola on the breast mound and the nipple pointing downwards. Patients a lot of time just mean that their breasts aren't sitting as high as they want. And so, plastic surgeons, we're all sort of trained to think that the breast should look a certain way, but sometimes patients aren't bothered by the same things that we are. And so I think it's important to talk to the patient and figure out, all right, what are your goals? Many patients will tell us, look, I just want to have more volume and I want to wear a bra that's going to allow me, when I wear that bra, to have more volume in the upper portion of my breast. And I'm willing to do that. In that situation, even though a patient may meet the classical need for a breast lift, sometimes we'll compromise on that. We'll think about using an implant. If patients, though, tell me, look, I want to look as though I'm wearing, I want my breast to be standing up and I never want to have to wear a bra. I want my breast to look like that. And they meet the definition of needing a breast lift. There's no way to do that without the scars. And yeah, scars can be a hard sell for patients, but nobody has ever come to my office, and I suspect it's the same with you guys as well, that said, hey, Dr. Jejurikar, what I really, really want is all these scars on my breast. I would really love an incision around the areola and a straight line coming down and maybe one across the bottom. That's what I really want. Rather, the people that come in are just sort of reconcile that that's what they need in order to get the look that they want. And they know they're going to have to do some pretty intense scar care for 6 months to a year to get the results that they want, and they're willing to do that. And so that, I don't know. I'm not sure I answered your question. It kind of comes down to what patient goals are.
So the way that I approach a patient is, like you said, how we are generally trained. I tend to break up patients into 3 categories. If they are coming in for breast augmentation, one category is that they clearly do not need a breast lift. That would be generally the younger patient who maybe hasn't had any kids or just generally has a youthful breast. The second category is the patients who definitely need or definitely would be recommended to have a breast lift. Those are the patients whose breasts are hanging down to their abdomen. Maybe they've had a lot of weight loss. Maybe the elasticity of the skin is all gone because of various factors. And those patients would generally not look aesthetically normal if you just put an implant in them, because for viewers, when we put an implant in, the implant is going to sit eventually at where your breast is. And if the rest of your breast is hanging way below the breast fold, you're going to have volume up here where the implant is and the rest of your breast sitting low. We call that Snoopy breast deformity, and that generally doesn't look good. And then you have the sort of in-between patients who you could possibly recommend an implant with breast lift, or maybe just an implant on its own. And I think that's what Sam was alluding to. Sometimes you have to tailor the procedure to what the patient wants, because what I tell patients is, if you just want to look good in a bra, then doing a lift won't really do much for you, because the bra is going to be doing the lift. But if you want to look good in the nude when you come out of the shower, you want to wear and have the breast lifted and nice, right? Then you have to consider getting a breast lift with the implant, and with that, there's going to be scars associated. So, even though you may think one procedure is better versus the other, oftentimes letting the patient guide you will be the right way to go. So I break it up into, definitely does not need a lift, needs a lift, and sort of the in-between patients. So the in-between patients are ones who might have to spend a little bit more time discussing the options. As long as a patient knows what the consequences or outcomes of any decision that they take, then I would be okay.
I think.
Hey, can I?
Yeah, go ahead.
Sorry, I was going to ask a question. So the question is, I know we started off talking about breast implants, but this is a really interesting thing, kind of dovetailing on breast lifts. How many times do you guys find yourself talking to a patient that comes in who wants a breast lift and wants an implant, and you see a patient and you think, okay, I can do this, but I don't really even feel comfortable putting in an implant at the same time? Do you ever encounter that? And who are the patients that you typically have a hard time putting an implant in at the same time you would do a breast lift?
Go ahead, Larry.
Yeah, go ahead.
No.
So I would say that when I see a patient, if they already have a fair amount of breast volume, then you have to ask why the patient wants a lift. Meaning, you can sort of simulate what they would look like when you're examining them. You gather their skin and you show them, okay, we just did a lift. This is what it would sort of look like. Would you be happy? This sort of volume? And if they're okay with that, then I would say maybe you don't need a lift. But patients who we wouldn't put an implant in would be that type of patient, or if a patient is, looking for something that's much larger than what can accommodate their skin. Because when we put an implant in, we're stretching the skin because we're putting more volume in. And then when we're doing a lift, we're removing skin as well. So you have this double whammy of reducing the amount of skin. And if a patient wants an implant that's too large to accommodate that, then I wouldn't necessarily say they can't have an implant, but we have to talk about going to something smaller or, having their expectations changed.
Does the degree of droopiness preoperatively have an impact for you at all?
Oh, yeah. So if patients clearly don't need a lift, then I would generally say, it's not necessary because the position looks good. You don't have excess skin. And, oftentimes patients may be under the perception that they need a lift, but then when they come in to see us, and that's why, we do the consultation to give them large, but oftentimes
I guess what I was actually asking you was, what if it's really, really, really droopy, like the nipples pointing down to their feet, and they're massive weight loss patients? Do you worry about, doing a relatively large lift on someone and putting an implant at the same time? Do you have concerns about healing or blood supply, or is that not really a thing anymore?
For me, I've gotten more aggressive as my experience has grown. So as Larry said, an augmentation mastopexy is, I mean, we were taught this, one of the most challenging cases. They used to quote us that this was one of the most litigated cases ever, because what Larry said is you're stuffing like a 10-pound sack of potatoes with 15 pounds and then tightening that sack at the same time. So that has always been one of the challenges that traditionally we've learned about, especially when you're doing all that tissue rearranging in a breast lift, and then you're squeezing the crap out of it by putting a tight, making it tight by putting an implant underneath. That was something that I've gotten more confident with over time. I think knowing how tight to make it and how much you can get away with depending on the degree of ptosis and how saggy it is something that all of us as surgeons have learned, I think, the more you do it. That being said, I have done it both ways, where I've staged it, where I've done a lift and then I've gone back and put an implant in. I've also done a single stage with some pretty massive weight loss patients and been pretty aggressive with it. And I will say, cosmetically, I think the results, at least for me, tend to be better if I do the lift first and then I'll put an implant in. Sometimes even with a little bit of a revision the second time around. But I have gotten some pretty decent to really good results doing it. And I've kind of pushed the boundary a little bit on that. And I think these massive weight loss patients also are going to accept a little bit more sagging. Like you said, their concept of sagging and our concept of sagging is a little bit different. So if I can get that implant in the right spot, if I can get the breast volume pretty good around that implant enough and avoid that Snoopy deformity or waterfall deformity that Larry's talked about, then I'm in a pretty good spot. And I've tried to do more and more of those. And I think, it's a question of me sort of just understanding what that relationship is between the two. How about you, Larry? Sam?
Yeah, I was more picking your brain out of curiosity, because there's not like a black and white answer to any of these things. Larry was saying you don't want to pick an implant that's too big. I 100% agree with that. But then my concept of what that too big of an implant is, or what the profile of that implant is, changes over time and changes on what the patient is. I've been putting it, I've even had situations now where I put in some reasonably large implants, like in massive weight loss patients. This is Texas after all, and everything is bigger in Texas. And but I'll use mesh, and I'll tell them, look, I feel pretty good that I can get the implant to stay in the right position, but your skin has a reasonably high probability of relaxing and getting this waterfall deformity afterwards. And we'll have to do a revision in 6 months to a year on it if that happens. But, it's at least during that first stage, you'll have the volume that you want, and there's a chance that won't happen. And so I try to be upfront with people about the risk, because, you're putting this heavy weight in and you have minimal support. The reason we're there is because their support's not very good, but ultimately, yeah, I don't think there's any hard and fast rules to it. You just have to sort of weigh the pros and cons with each individual patient and see what they're comfortable with.
I think Andy Trussler has always told us, I remember we did an episode with him, and he talked about how, these are sort of moving targets. Like, you can do a mastopexy and it can look amazing. And then in 10 years, gravity takes over. If you have a big implant in, like you said, We try to mitigate that sometimes with more support, as you mentioned, but none of these are forever procedures. And I talk to patients about that, like especially if their life changes, they lose a lot of weight, they gain a lot of weight. Like these are all sort of things that can change. Even if on the table or the first year or two, like you said, they look awesome or they look great, things change. And so what we're trying to do is figure out how to make these results as long lasting as possible, as stable as possible, but also work within, you know, a bunch of pretty complicated parameters sometimes when you're trying to figure out what's how to achieve a patient's goal.
I'm curious to hear from both of you when a patient is sort of in that gray zone where they could get an implant, or sorry, could get a lift or not a lift, but they choose not to do a lift. Are there other things, other procedures, or other ways that you would go about to try to achieve the best cosmetic result possible?
So you're talking about a patient who's got like
Maybe a little bit of drooping. Yeah.
A little bit of,
maybe.
okay. So in those patients, if we're already doing an augmentation on them, sometimes I will do a little bit of concomitant fat grafting in addition to an implant to add even more upper pole fullness than I might be able to get from the implant, knowing that the implant's going to be sitting a little bit on the lower side. But I don't find mesh to be particularly useful in those situations, because I'll find that if I use mesh in those situations, the implant sits abnormally high and they have even more of like a waterfall deformity, or a Snoopy deformity where the tissue's hanging off of it. Sometimes if the patient is amenable to it, we think about going slightly bigger with the implant to recruit more soft tissue. But that comes with risks, that when you use a bigger implant, you create more force on the soft tissue, and the laws of physics are merciless and never change. The greater the mass of the implant, the more the force of gravity is working on it, and the more long-term sagging they may actually, experience. But sometimes we'll think about a bigger implant. Sometimes a bigger implant in mesh. There's not really like a set. It really, again, comes down to what they're willing to tolerate in terms of implant size.
We talked about this just before we started the podcast. I don't do very many subglandulars, if ever. And I do know that there are some people out there that feel that subfascial can get you versus submuscular can get you a better look in mild or moderate ptosis patients. Do you guys do that?
I don't do that very often, but the theory behind it is that if you place the implant over the muscle, then you're sort of going to fill out the skin envelope a little bit better. And so you don't have as much apparent drooping because the implant just sits slightly lower than where it would sit when it's under the muscle. So I think that those options are definitely on the table. There are, pros and cons to that approach. Maybe a little bit more premature drooping, as you guys have mentioned previously. But, I think subglandular or subfascial, the difference between that is when it's subfascial, you're going slightly deeper or more under a layer that helps to give a better contour to the upper pole of the breast, and maybe some improvement in reduction of sagging. But I think that's sort of not certain at this point in the evolution of that procedure.
Yeah, I do subfascial breast augmentations, and I wish I had mentioned that when Larry asked the question in the beginning, but I will use it for people that have that in that gray category. I guess the one thing where I feel a little differently than Larry is I don't really believe that going subpectoral prevents long-term sagging any more than going subfascial. Maybe it comes down to how much you release the lower portion of the muscle. I think I'm fairly aggressive in that release. But for that reason, I think, to me, I don't think that the soft tissue, whether there's that lower pull where there's not really, even in a subpectoral or a submuscular augmentation, there's not a lot of, anything other than skin and breast tissue holding it. I think that ultimately it comes down to implant size more than the plane of where you're putting the implant in terms of preventing the sagging. The theory behind subfascial is that this thin anatomic layer, the fascia of the pectoralis major muscle, is enough to provide a barrier protection between the breast gland and the implant so that you have more protection against capsular contracture versus just going behind the gland itself. And I say the theory because I don't know of any compelling long-term data that actually shows that. And it's not the thickest layer in the world. So I do tell people, this is the theory. I can't tell you with certainty that it's as safe for preventing hardness of your implants than going behind the muscle. But there's definitely patients that I will talk to about doing this and will do it for.
It's funny. I think this is one of the types of procedures where having a lot of experience does help. Like, I can't tell you exactly what degree of sagging objectively would prompt me to tell a patient, I don't think I can achieve the result you want without a lift, regardless of whether it's subfascial, subglandular, submuscular. But I do know it. Like, I can see it. Like, if I see it, I would be able to tell you. But I wouldn't be able to say, articulate it and write it down in some sort of analytic fashion about this measurement means this patient needs a lift, or this measurement definitely says this patient doesn't and can get away with a subfascial, or whatever it is. It's kind of weird to me. It's just one of those things that I feel like every surgeon is fairly individual with. I've seen a lot of different sort of methods, thoughts, analyses. And as long as I think experience counts, I think the more you do these, the more you know what you can achieve, the more you can try to understand the patient's goals. I mean, I really do understand most patients when they really don't want any scars on their breasts, and I will do anything that I possibly can to avoid that. But there is a point where I see someone's anatomy and I'm like, I'm sorry, you maybe go see someone else, because I personally will not be able to do that for you. And I've gotten to that point where I'm comfortable understanding which ones I can say that to, which ones I can actually help them achieve their goals. But it's taken me a while to get to that point.
Yeah, for sure.
So what about?
Oh, sorry, Larry.
Oh, I was going to say, when you guys do mastopexies, breast lifts, we had mentioned the decision. So there are various forms of breast lift, and do you guys use all the different forms, or do you like to stick to sort of your tried and true techniques when you do these surgeries?
I think my general rule of thumb is, I shouldn't say rule of thumb. Sorry. My general rule is that the milder the degree of droopiness, the fewer incisions that I want to use. That being said, the traditional incision that is just around the areola, which is called a Benelli for the listeners, isn't really great as a true breast lift. I really use that just for patients who want their areolas made a little bit smaller. I will sometimes do a lollipop lift for milder degrees, which is an incision around the areola and a vertical line extending downwards. But more often than not, I have to add a transverse component in the crease as well, just to shape the breast the way that we want to.
Yeah, I have gotten away from the Benelli, which is just around the areola. I haven't done it in years and years. I will see if I can just do a lollipop, but most of the time I have to tee it off maybe about an inch or two on the bottom. It's really hard for me to get away from just even a little bit. And I always feel like if you've made that vertical incision, you've basically made the most visible scar. So to put on the breast fold an inch or two just to tighten it up or sort of finish it, like, to me is less of an issue than committing to that vertical incision, basically. But I will never, I don't know. It's very rare that I would ever consider, like Sam does. Like, I'll do it for a real reduction, but I don't think I would ever offer a Benelli for a real mastopexy.
Yeah, I would agree with everything both of you had said. Basically, tailor your surgery to the anatomy. If you can get away with smaller procedures, smaller scars, then do that. But as needed, use the scars, use the incisions that you need to get the best shape. Because I think in the end, the overall shape will really trump whatever scars patients had. And I found that to be totally true. Patients generally, if they have a nice shape, they're going to be very happy, and they're not as concerned with the resultant scars, because scars will fade, scars will heal. You can do things to improve them, as long as they know that they're never going to go away.
I will say this. One thing I have learned is the key for me to getting a longer lasting repair is keeping that from the areolar down to the inframammary fold distance short. Like, every time I've left that long or what I thought was okay, that always lengthens. I think Trussler said it's like a tail on a lizard. It just keeps growing. So if you can get that distance from the inframammary fold up to the areola short, like, meaning like I don't ever leave it more than maybe 7 centimeters if possible, even shorter to 6 if I can get away with it. I generally feel like the long-term result's going to be better for me.
Yeah, and implied with that for viewers is that in order to shorten that incision, you have to make that transverse incision.
That's right.
Yeah, I agree with that. Though there are certain implant selections where if you use a higher profile implant, sometimes you can recruit some of that skin. So that's true, but there's a few situations I find myself in where I can artificially reduce that length. But I'd say 90% of the time I make a transverse incision. So I'm not claiming that I don't. I was just sticking to the spirit of the question.
What?
Well, this has been very illuminating, gentlemen. I, as always, have learned a lot from the two of you, and this is a trend that's continued over decades. So thank you for doing it again this morning. Do you guys have any closing thoughts before we wrap this up?
No, always a pleasure.
Yes, always a pleasure. We are recording this in the morning of Christmas Eve. So by the time people will hear this, it'll be after the holidays. But I'll say to my buddies now, have a great holiday season, spend some time with family, and I look forward to seeing you guys again.
Happy holidays.
Well said.
Happy holidays.
Thanks so much.
All right.